All right. Good morning again, everybody. Happy New Year. Put up the PowerPoint in one moment. All right. So once again, Happy New Year, everybody. It's good to see everybody on here. Hope you all had a good end of 2023 on 2024 here. So let's get started. Here's our agenda. We did move things around from our normal a little bit. We have some special guests. So we are going to start with our normal updates on anything related to the OMSAS and the meetings that the behavioral health MCOs have. We do have our director of compliance on, so she was able to, with some feedback from compliance audits as well as the IBHS care managers, put some slides together to talk about some compliance things related to IBHS. So we're happy to have her on today. Crystal is here again for our network updates. And then we have our clinical updates, a little bit of clinical data, and some upcoming information and resources as well in our questions. So not too different than normal, but that is our agenda for today. So I will start with our updates from OMSAS. We did actually wind up changing the frequency for 2024. Instead of a monthly meeting, it will be an every other month meeting. So our next meeting is February. So there will be some less frequent updates probably in that way. One of the things that was shared though at that last meeting was a possible resource for autism and ABA trainings from the University of North Carolina. They are approved for CEUs and they do, it was noted by OMSAS that this does meet the criteria for department approval for trainings. So it was shared as a good possible resource for you guys as providers. So I don't know if I can multitask. Maybe when Carly comes on, I can try to put this link in the chat. Obviously, we also do within a couple days put up the PowerPoint and the recording, so you can grab it there. So I'll try to do that when I'm not talking. So hopefully that can be a resource. Let us know if that's a positive one for you. And then this was something we did discuss at the last one, and beyond saving the date, you can actually register now. So it's the Children's Interagency Conference, Shine the Light on Mental Health. It's at State College on April 22nd through the 25th. Again, they are booking like hotels, and the conference registration is open. So if you want to take a look and see if that's an interest, please do so. It sounds like it's going to be a great few days on spotlighting those issues. So again, not too many things to report on the OMSAS meeting level. I'll talk a little bit later that a lot of our agenda and time had been spent on finalizing the updated reporting requirements, which did happen in December. So that's what we spent some time talking about. So again, I will share that a little bit more when we get to the data section. So we have section on compliance. And again, I said we have our Director of Compliance, Carly Schillings, here with us today. Super happy to have her. So she's going to be talking to us. We'll keep an eye on the chat, and maybe at the end of Carly's time, we can see if there's anything specific for you, Carly, related to anything here. So I'll turn it over.
Thank you. Thanks for having me this morning. Probably intercrossed with some of you through emails or other conversations. So I appreciate you carving out a little time for me to talk today. I was asked, as Kristen said, to speak today about some reminders about the importance of following regulatory guidance, as well as some of the audit trends that we've seen specific in our review of IBHS providers. And then I'm just going to share some reminders about confidentiality and consent to treat. So you can go to the next slide, please. So I'm going to start just with some reminders about the IBHS regulations. I'm sure everyone in attendance today is more than fully aware of the regulations under chapters 1155 and 5240 of the Pennsylvania Code. 1155 are the payment policies for IBHS, and chapter 5240 sets forth the minimum requirements to obtain and maintain a license to provide one or more IBH service. So as a licensed, enrolled, and contracted IBHS provider in Magellan's network, of course, you are required to follow these regulations, both under your license with DHS, but also with Magellan, because we pay your claims. So language within our contracts does require you to be in compliance with all of the state regulations. And on this slide here, I've just included some relevant sections of chapters 1155 and 5240 specific to payment for IBHS providers being contingent on meeting all the provisions within the regulations. It's important to note that also under the Health Choices Program standards and requirements, we must ensure that our network providers that are delivering state plan services and participating in the Medicaid program in Pennsylvania do comply with all federal and state laws. You can go to the next slide, please. So both the 1155 and 5240 regulations are extensive. There's a lot of detail, as I'm sure everyone is well aware. There are requirements for timeliness of when a written order, assessment, and treatment plan must be completed and updated, as well as what components need to be included in those assessments and plans. There's requirements about what education and credentials staff must have and maintain. And, this includes the administrative director and a clinical director, as well as those staff that are rendering care. There's requirements for how often supervision is required for staff and who can provide that supervision. There are requirements for how much training staff need to receive, what type of training, and what and how the documentation for that training needs to be maintained. And of course, these are just a few of the components. We do understand it's a lot to know, a lot to keep track of. With that being said, it's just important to understand that if Magellan does find deficiencies in any area of the IBHS regulations, whether it's from Chapter 1155 or 5240, it could result in a corrective action or recovery of previously paid claims. Just give a couple examples. If you have a treatment plan that is expired, or worse, a treatment plan was never completed, all services that were rendered for the life of that treatment plan are subject for recovery. Or as another example, if you have a clinical director that maybe doesn't meet the minimum qualifications, all claims that we paid while that unqualified person was in their role as clinical director are also subject for recovery. It's just important to be aware of the requirements, but also understand what the implications are. And I'm not here to try and scare anyone. We are really trying to help providers understand what some of the consequences are so we can prevent them from occurring. That's really the basis for the presentation today, is we're trying to avoid these situations as much as you as providers don't want to find yourselves in these situations. It's really also important that your agencies have someone dedicated as a compliance lead or compliance director that can manage and provide oversight, because again, there are so many requirements. So it's a really good practice to have a dedicated person in place that can manage all of these requirements for you. What we're seeing is that because there's a lot of turnover within provider agencies, the knowledge or understanding of the regulations or requirements is not always transitioned to the new staff. You can go to the next slide, please. So now I'm gonna talk about some of the trends. So in October of 2023, Magellan conducted our annual provider compliance forum. And if you were not able to join us, I would recommend that providers go back and listen to the recording that's available on our website. I'll share that link later during this presentation. It's available on our website under compliance alerts. So this slide that I'm showing here is a duplicate of the training that was provided in the fall. So if you did attend that training, some of this is going to be a duplication, but just wanted to bring it to this group here. Really want providers to be aware of the most common deficiencies we are seeing when we're doing some of our auditing of IBHS providers from a compliance perspective, just so you can avoid some of these situations. I'm not going to review all of the trends here, but we did want to focus on some of the 4 most common that we're seeing in IBHS. So I did bold those here on this slide, and that includes issues with rounding, encounter forms, telehealth documentation standards, as well as signatures. So now I'm going to review each of those in a little more detail. So next slide. The first trend I'm going to review today is related to concerns we've been seeing with providers rounding up when the full unit duration is not met. So the number of units, or I'm sorry, the number of minutes that equates to a billable unit is dictated by what's referred to as the state's covered services classification chart. We use this state guide to develop our provider reimbursement schedules, and those schedules list not only the rates and codes you must bill with, but also the unit definition. So for a lot of the IBHS codes, for example, most codes are defined as 15 or 30 minutes, and the number of units you submit on your claims depends on how much overall time is spent rendering care to the member. Those unit definitions are exact, and you may not round up when determining how many units to bill. So for example, if you did not provide the full 15 minutes and the service that was provided lists 15 minutes as the unit definition, you may not bill for that time. So there's 2 MA bulletins that outline the requirement that providers must bill for full units of service. Those guidelines do not allow for rounding when services are measured in incremental time-specific units. So I've included the references to those 2 bulletins on this slide. OMSAS has, through level of care specific regulations and the bulletins I've referenced here, has permitted exceptions for 3 in-plan services: case management, crisis, and family-based. But the general rule for Medicaid providers is that rounding is not allowed. It's really the exception, not the rule. So IBHS providers must provide the full unit of service and may not round up in any situation. We are aware that there's some coding resources out there that may mention different guidelines, but if you are billing any dollars to the PA Medicaid program, and that includes cases where we might not be the primary payer, you are required to follow the PA Medicaid requirements, which means no rounding. All right, the next trend I'm going to review in more detail today is encounter forms. You can go to the next slide, please. Encounter forms are intended to offer an extra check and balance for an agency to ensure that services are rendered as document. And this mechanism for oversight is best enforced by obtaining pertinent information, which can verify the provision of services. We really see securing and monitoring encounter forms as a mutual aid for our battle against fraud, waste, and abuse. In accordance with MA Bulletin 998905, providers are required to obtain signed encounter forms to certify that an individual did receive a service. I included the hyperlink here to the bulletin on this slide, and that bulletin outlines the minimum requirements for encounter forms, which includes the certification statement you see here, provider name and MA ID number, the recipient's name and their ID number, the recipient's signature or the signature of the recipient's agent, which could include their legal guardian or caretaker, and the date of service. And then in addition, Magellan requires providers of community-based services, which includes IBHS, to obtain signed encounters for each face-to-face contact that results in claims being submitted to Magellan. Providers may determine how they will monitor and comply with the requirement. However, at a minimum, we do require for all the information that's outlined in that bulletin, MA bulletin, to be on the encounter form, as well as the start and end time of the session. We do not prescribe a template for these encounter forms, nor does the state. They can be developed by your agency, but they should include the minimum requirements that I outlined here. I did just see a question come through the chat about whether progress notes are sufficient to meet the encounter form requirement. And yes, as long as the progress note includes all of the minimum requirements that are outlined here, that can serve as the encounter form if the member or guardian is signing off on it. You can go to the next slide. Just some additional reminders about encounter forms. If you're unable to obtain a signature on an encounter form, which includes a refusal, it should be documented why, and then attempts should be made to obtain the signature the following session. For example, if there's some sort of crisis situation that's going on and you're not able to obtain the encounter signature on that date of service, it can be obtained on the next date of service. The signed encounter form should be part of the individual's medical record or otherwise available for review at the time of an audit. And providers or employees of a provider are not permitted to sign encounter forms on a recipient's behalf. The emergence of telehealth has introduced some complications with getting signed encounter forms. Although utilizing telehealth in IBHS is not always preferred, we still want to make sure that some reminders about encounter forms following telehealth sessions are shared. Per the current state telehealth bulletin, which is OMSAS 2202, signatures for service verification may include handwritten or electronic signatures. There were some OMSAS flexibilities in place during the public health emergency. However, as of January 1st of 2024, all of those flexibilities have expired and providers are expected to capture service verification in a manner that creates an auditable file. Audio only verification can be obtained by either having another employee of the entity here, meaning 2 people, and documenting that consent, or by utilizing a mechanism such as a telehealth platform, or obviously mail, email can be used also to obtain signatures. And just as a final reminder, back on August 10th of 2023, all HIPAA flexibilities related to telehealth also expired. So starting on August 10th, providers were required to be using a HIPAA compliant telehealth platform. And since HIPAA is a federal regulation, the state has no ability to change or extend a federal requirement. So providers should now all be compliant if you are using telehealth with using a HIPAA compliant telehealth platform. And if your platform is HIPAA compliant, you should be able to obtain an electronic signature. All right, next slide, just a couple more comments on encounter forms. We've wanted to share some best practices. These are things that we've observed other provider agencies doing, and they've all found to be effective when in terms of deterring potential fraud, waste, or abuse. Ensure that families are well aware at the onset of services that staff asking them to sign a blank encounter form is not an acceptable practice. This can be included in your intake paperwork or family handbooks if you have them. You could incorporate this issue related to encounter forms and the potential for falsifying or asking families to sign blank encounter forms into your annual compliance trainings. The issue can be prominent with contractors. So if you're using any contracted employees, have these staff sign an additional attestation that they will not engage in this practice. It's important to have a policy or procedure in place regarding encounter forms and all of the expectations and guidelines, and incorporate the review and comparison of progress notes and encounter forms into the routine auditing and monitoring process. You could compare family or member signatures across time to ensure that they match. So again, we're sharing these best practices so providers can help protect themselves. So the next trend, you can go to the next slide here. The next trend I'm going to mention briefly are just some documentation reminders when services are provided via telehealth. Adherence to all regulations and requirements still apply to the service being delivered by telehealth as they would if the service was delivered face-to-face. And that includes following all of our minimum documentation guidelines, which are found in your provider handbook supplement. And then in addition, if the service is provided by telehealth, at intake, you must have consent from the member to receive services via telehealth. The documentation should include the mechanism for how services were delivered, such as telehealth, phone, face-to-face, whatever it is. The documentation should include the platform that was utilized, and it should also include the member's phone number that was utilized if the session was provided by phone only. All right, next slide. The last trend I'm going to review in more detail today is related to signature requirements on documents. There's two considerations here. What does the law say and what does your policy and procedure say? So just to be clear, providers should definitely have a policy or procedure in place about the expectations for signatures, when they need to be in place, who can sign, etc. So the policies and procedures should be based on whatever the applicable law or state requirement is, but your policy should also include additional details with how you'll ensure and maintain compliance and other nuances that might not be covered by the regulations. I'm going to just go into some basics about signature requirements. Whether the IBH service is provided in person, telehealth, or audio only, providers are expected to capture consent to treatment, service verifications, and approval of treatment plans in a manner that creates an auditable trail and is in accordance with the timelines within the IBH regulations. Signatures for consent to treat may be physical or electronic signatures unless prohibited by other laws. And consistent with Act 69 of 1999, Electronic Transaction Act, an electronic signature is an electronic sound, symbol, or process attached to or logically associated with a record and executed or adopted by a person with the intent to sign the record. So providers using electronic signatures must have systems in place to ensure that there's an audit trail that validates the signer's identity. All this information is contained within the current OMSAS telehealth bulletin as well. It's not, it's obviously pertinent to services delivered via telehealth, but also includes some important reminders about, signatures for face-to-face and other types of service delivery as well. Physical signatures can also obviously be obtained through a variety of different mechanisms, including in-person, face-to-face sessions with a member, through U.S. mail, when you're sending copies of forms to members to obtain their signatures, or through email. In terms of treatment plan signatures, telehealth platforms that utilize a checkbox for the recipient of services to agree as a method of capturing consent for treatment plans are permitted, as long as there's also an option to not accept the treatment plan. Treatment plans, again, as we discussed a little earlier, are required to have an individual or parent's signature attached to the record. Signatures can be obtained using a telehealth platform or by acquiring signatures by U.S. mail or email as soon as possible, but no later than 90 days after the service. And the signatures must be on file before claims can be submitted. If you do have other ideas, creative ideas for how you've obtained signatures from members, I'm sure that providers would value hearing about successful methods. So, if you want to put in the chat, if you have any suggestions or best practices related to this practice, that would be great to share. All right, you can go on to the next slide. Last couple of slides here. I'm going to move into a review of Act 65 now and just some reminders about confidentiality. Here on this link, I've included a hyperlink to the DHS bulletin on Act 65. This bulletin was most recently updated in 2023, early in 2023, but was also reissued in December as a reminder for providers. On the next few slides here, I've included just some screenshots from the DHS training on Act 65. This training is actually included as an attachment along with the bulletin that is hyperlinked here. So we do encourage providers to read the entire bulletin and training that DHS provided. Right now, I am going to just review a couple of the slides of information from that DHS training. So what is Act 65? It's a state law that was signed by the governor back in July of 2020, and it replaced Act 147. Why is it relevant? It's important for providers, especially IBHS providers, sorry about my dog, who primarily service youth, because Act 65 determines who can consent for voluntary mental health treatment of minors in both inpatient and outpatient settings. It also determines who can consent to the release of an individual's medical and mental health records. The intent of Act 65 is really to enable behavioral health treatment to begin when consent is received from either the minor, parent, or legal guardian. And Act 65 governs the mental health treatment of minors in conjunction with the Mental Health Procedures Act, otherwise known as MHPA. So it's important to have awareness of both laws. Next slide, please. So who can consent to mental health treatment in the state of Pennsylvania? I'm sure most of you, if not all, are aware of this, but minors who are 14 years or older can consent to voluntary inpatient or outpatient mental health treatment for themselves without the consent from a parent or legal guardian. And a parent or legal guardian of a minor under the age of under the age of 18 can also consent to inpatient or outpatient mental health of their minor child without the minor's consent. Next slide, please. So who can object to consent? It's important to note that neither Act 65 nor the Mental Health Procedures Act address if a parent or legal guardian can object to voluntary outpatient treatment for which a minor has provided consent, and vice versa. There's different language for objecting to inpatient care, but since we're talking about IBH services today, we won't get into that. Who can revoke consent according to Act 65? A minor or parent legal guardian can revoke their consent to inpatient or outpatient treatment at any time. If a minor provides consent, then later revokes it, the parent or legal guardian can provide consent for the treatment to continue, and vice versa. Who provides the consent is really important because it dictates who controls the individual's records. The control of records is with the consenting party. So when a parent or legal guardian has consented to the mental health treatment, they can also consent to the release of the minor's mental health records. However, it is important to note that the release of records with the consent of the parent or legal guardian are limited to direct release from one mental health treatment provider to another or to a primary care provider. So in other words, who consented to Act 65 does not have any role in how Magellan decides to release records, but it's very important for providers, and it dictates when you can share with other providers and primary care physicians. So next slide, please. That's a good segue just into some other reminders about confidentiality. Providers should develop and maintain their own policies and procedures that align with both HIPAA as well as Act 65 and other applicable state regulations regarding who can consent to treatment and sign documents. Providers should develop and implement their own release of PHI forms to coordinate care with other treatment providers, service systems, and member supports. Magellan's release of information form, we call it our AUD form, or our authorization to use and disclose form. An AUD that is completed in full and signed by the appropriate party allows us to share an individual's records with a third party. We did recently update our AUD form in the fall of 2023. So if you have old versions lying around, please discard them, start using our newer forms, which we did attempt to make more member friendly. I did include hyperlinks here on this slide for both our fillable form as well as our online submission form. We do strongly encourage members to use the online form. So if you're working with an individual or family, please direct them to the online submission option on our website. Just want to call out that Magellan always operates on the assumption that a minor child age 14 to 17 understands and has consented to treatment. Thus, we need the members' permission to speak with their parents and anyone else. And then Magellan AUDs requesting that we share information with a third party must also be signed by the minor age 14 to 17. Since Act 65 does not apply to Magellan's release of information, we rely on the Mental Health Procedures Act, which states that when a client 14 years of age or older understands the nature of documents to be released and the purpose of releasing them, they shall control release of their records. So for an individual who lacks this understanding, such as in cases where you have an individual who has some intellectual disabilities, any person chosen by the patient may exercise this right if they're found by the director to be acting in the patient's best interest. So that's from the Mental Health Procedures Act. All right, my last slide today is just some compliance resources. Some of these have been referenced earlier in my presentation, but I've included hyperlinks here for everything. First, if you're not aware, we do send compliance email blasts on a monthly basis. At times, the communications are specific to a single service or level of care, so they might not always be applicable to you. However, most times the communications are relevant for all provider types. If you want to be added to receive these emails, you can send us an email, and I have that at the top of this page here, the PHC compliance email. Regardless of whether you receive them directly, you can always view them on our website. We have all of our communications going back to 2013. And as I mentioned earlier today, we host a compliance webinar annually for providers, and I've included the links to the recordings for both 22 and 23 here. On our dedicated compliance page, we have some helpful links, including how to prepare for an audit, fraud, waste, and abuse resources and toolkits, making a referral, audit trends, some of those that I mentioned earlier today, as well as some compliance best practices. And then lastly, I've included hyperlinks for the guidelines related to conducting internal self-audits, how self-reports should be made. Providers should be auditing themselves on an ongoing basis to ensure compliance with the regulations, as well as claim submission practices. So hopefully some of those resources are helpful for all of you if you weren't already aware. I do appreciate everyone's time and attention today to these important topics. I am available for follow-up questions or concerns. You can always send an email to that email address that's shown on the top of this slide. I'm not sure, Kristen, how you want to handle questions. I can try and start going through some of them and answering them through the chat.
You had, I think it was only 2 at the moment. So yeah, if you want to answer them via the chat, that would be fine. It looks like 9:19 and 9:22 is when I saw 2 of them. Unless you want to answer them out loud right now.
I see the ones just scrolling through some of them to pull out the questions. The 2-staff, we can no longer use the 2-staff verification for telehealth services. No, that's still an option. That's one of the options for verification, is having a second staff person here. So sorry if that wasn't clear in whatever I said. There's a question about movements towards electronic visit verification. That has not been pushed down to behavioral health services at this point in terms of that being a requirement. I know it is in maybe some of the physical or other other services in the state, but it's not applicable to behavioral health at this time in terms of being a requirement. Of course, if you have a method, if you're doing visit verifications internally within your agencies and you have a mechanism or a way to do that, that's great. We would definitely encourage that. I think that was it.
Yeah,
But if there are
Emily.
other questions that come up, please, I'll try and monitor the chat for a little bit longer until I have to drop off and respond to anything.
Great. Thank you so much, Carly. This was super helpful.
Thank you.
All right. So next up are our network updates, and I'll turn it over to Crystal.
Thank you. Good morning, everyone. So I'm just going to go over some network updates. A lot of this will be a repeat from the last couple, but we just want to really drill some of this stuff home. So the first slide here we have is our network team, just contact information if you need that. All right, so billing usual and customary. So when submitting claims, we're just hoping that providers can start billing usual and customary versus their contracted amount. We're asking this because I'm sure everyone is aware that we just had those most recent rate increases. So there are some delays when we get those rates loaded into our system. And also some delays when those rate increases go out and they can have backdated effective dates. So just asking to bill for those higher amounts and allow for us to then capture those already submitted claims and reprocess. If a claim is billed with a lower amount than what that rate increase would be able to pay out, we would not be able to grab those and repay them. We would then have to ask for providers to resubmit those claims with a higher billed amount. As I said, we're automatically sweeping to adjust those to the higher amount. So no additional actions are needed from providers when these rate increases go out if you're billing those usual and customary fees. But as always, feel free to reach out with any questions you may have regarding billing those rates. Some billing reminders. These are some trends that we've been seeing specific to IBHS. We're seeing a lot of members' home addresses come in on claims, even some other locations other than your contracted rendering service. So if you're looking at your fee schedules, you'll see your specific Magellan provider ID number and the address that's listed next to it. If you're billing out of, if you're billing us, you're going to always want to use that address that's specific to that MIS number next to on your fee schedule. Another reminder is to bill with your contracted codes and modifiers as opposed to those auth codes. We do use a bucketing system, so authorization codes may differ than what is listed on your fee schedule. And modifiers need to be listed in the order that they show on your fee schedule. And then for any corrected claims that need to be submitted, it is required by Magellan now to resubmit those claims with the original claim number. We are seeing a lot of corrected claims come in under a new claim number, and you may be seeing a denial that says there's already a claim in place, or that it may have already paid under a different claim number. So just a couple billing reminders there. Okay, satellite sites and licensing. So this one again is really important. We are seeing some issues pop up regarding some different sites. What sites need to be MA enrolled, what sites need to be added to your service description. So there are 4 different regional offices: the Western, Northeast, Southeast, and Central. You only need to get multiple licenses if you're serving in multiple different regions. If you have multiple locations in one region, you do not need to get each site licensed unless you're providing on-site services. So any location that you have where you are providing on-site, that must be included on both your service description as well as your license, and also have specific MA enrollment. And then the provider is required to submit one service description for each license. So if you have multiple different licenses through different regions, you only need one service description for each. If there are any service changes, an updated service description must be submitted to the licensing field office for approval. If there's any address changes, the provider must also notify the licensing field office, as well as verify your MA enrollment. Again, can't stress enough that locations that are providing on-site services must have a license, MA enrollment, and that would also be an update to your contract here at Magellan.
I just wanted to also add, Crystal, is it fair to say, like, we want to make sure providers are, like, say, a new address, change of address, that it's notifying OMSAS as well as Magellan,
Correct.
that it doesn't trickle down. So those two pieces have to happen as well.
And the sooner you know, the better, because I know sometimes it can be a lengthy process with getting information from the state as well as getting that enrollment switched over. Okay, so new IBHS, either any type of expansion or this one specific to group, if you're interested in expanding that, so you can send an email to this email address below. You're going to identify your agency and note what you're looking to add, whether it's group, ABA group, both, even on-site services. We'll respond by sending a DocuSign link, which will then be sent to you for you to fill out. And then we'll need a copy of your service description and your MA enrollment update information. And then that will go into review. Once we receive everything, we'll review it in one of our in-office meetings, as well as then get approval from the specific counties that are being requested. For Magellan, if your agency is looking to move locations, add a new location, want to begin delivering that site-based service, or wanting to begin any type of IBHS or ABA services, we're going to ask that you reach out to our network department, again, by emailing that interested provider email box below. And again, any type of move or change that we are not familiar with can really have significant impact on reimbursement. Again, all sites need to have MA enrollment if you're providing those on-site services, as well as making sure that you have codes and rates into our system under those specific locations. Availity. So as everyone knows now, we've moved over to Availity for entering authorizations. So we just have this slide here for any type of contact information you may need regarding any issues that you may come across with Availity. And just a couple network reminders. So Magellan credentialing is updated every 3 years. So providers will be directly notified from our recredentialing team within applications, and that's about 6 months prior to your recredentialing date. We're asking that everyone go on to our Magellan provider website to make sure you have the appropriate contact information in there, because those applications will be either mailed directly or emailed. Promise enrollment, that revalidation is every 5 years. And the date that you're due for revalidation can be found directly on the website. Providers are encouraged to review this date and kind of keep it in a safe place. We don't get a lot of reminders for when that revalidation is about to expire. So again, make sure that that's done every 5 years. You can do it a couple months prior to, that won't change anything. It'll just kind of roll over. This is for all enrolled locations, as well as different provider types and specialties. And without active enrollment, there is that chance where reimbursement can be affected. And that's it for me. I did see a couple of questions come.
I was going to say, we've got people wide awake for 2024 here.
Oh.
You want me to read them, or are you okay? I see one from 9:40. It
Yeah, but
started.
sorry. Is there a timeline for getting back, David? Let me see. Is that specific to, is there a timeline of when those rates will be loaded and claims should start getting processed? If yes, we are actively daily going through. We were doing, I believe, rate increases are with the rates being loaded specific to level of care. I know a lot of them most recently were updated, so there's a good chance that either this week, next week, or the following week, you'll start seeing those higher amounts come through. And who do we notify at Magellan if we're looking to add? So again, there's that email address that was in here, and Kristen will send this out, and it'll be on our websites, the MBH Interested Provider Application at magellanhealth.com. Yeah, okay, so the new rate is loaded, but from 10, yeah, so again, all of our providers got rate increases across the board, so it's a significant amount of providers that need to have their rates adjusted and added. So it is a little bit of a process. We're hoping to have some updates soon, but like I said, I know a bunch of them just went through, so like if you're not seeing them within the next 2 weeks, you can reach out and let us know. I think that might be it for me.
All right. Thank you, Crystal.
Thank you.
All right. Oops. Okay, some clinical updates and reminders. So it was a bit of a crazy ending to the last year, but so some of you are aware, but some of you may not be aware that Keisha Muller, who was our autism care manager, accepted a position with our commercial line of business. So she's still at Magellan, but not in our PAHC line of business. So, and many of you have had contact with her. So in her 3 years, she was truly instrumental in helping Magellan and you guys as the provider network in transitioning to IBHS. Her subject matter expertise in the regulations and ABA was exceptional. So we are backfilling, and I'm currently interviewing. So that's posted on our website. But I do ask gently for some patience with Emily, Ashley, Felicia, and Cheer, who are the IBHS care managers now, as they support our members and providers with just that one less team member until a new care manager is hired. So if you notice a little bit of a delay in response, you feel free to outreach me directly. Many of you do, or honestly, that IBHS website email page would be good for, generic things, general questions, auth error, things like that. I can try to pitch in and help this team as well. So just wanted to make everybody aware of that. Also, with the new I was going to say new, I don't know at what point it becomes not new because it's May 1st, but the online authorization edits or authorization edits period. Again, given the fact that we are sort of down one team member at now, and just to streamline the overall process, if you are checking authorizations and realize after you submitted something, this is no way to change it after the fact on your end. If you would email that IBHS, ideally, because I've asked the team that I'll sort of be that hub for that. And if you can outline some of the things here. So if it was already authorized, I realize sometimes you send it and you're so quick to catch it, which is awesome, but it's not even authorized yet. If there is an auth number, that's super helpful. Who submitted the auth? And again, as an oversight, we're just trying to see, is there somebody specifically who needs maybe some additional training resources to understand how the system works to avoid that? Because again, anything that's an error in the authorization that somehow winds up through could definitely impact your claims, and we want you guys to get paid as quickly and easily as possible. So the date the auth was requested, what was the error? So I left off a modifier, I put the wrong modifier, I put the wrong units, whatever. If there's a specific reason, how was the error discovered? Again, that helps us know, like, hey, we were doing what what we're supposed to. We're checking after the fact, or supervisor caught that when they were checking, or claims caught it. Unfortunately, we already had denied claims, and then it came back to us. So just looking to see, again, if you send it to the care managers, they're probably going to send it on, just trying to help the team out with some of these types of requests. Just want to call out, this is not new. We've been doing this for a bit, but just wanted to talk a little bit about specifically this intervention that we've put in with the higher level of care collaborative phone calls. So I run data twice a month that really tries to capture anybody, any member who has an active IBHS authorization that either just came from an RTF level of care, or was recently in an inpatient mental health hospitalization. And we then initiate, I tell the IBHS care manager that's assigned to the IBHS provider, and they outreach to give you a call to have a conversation. It is not a whole, let's unpack their 3 years of treatment. It really is supposed to be a short, quick conversation to make sure that the provider was aware. Were you involved in any of the conversations with the hospital or part of that transition? Hospital seems to be the most that is happening, but we do it for RTFs as well. Is there anything we can do to assist? Is there any kind of barriers that you're noticing? Did you guys sort of see that maybe this decomp was happening? Do you have any insight? Again, we touch and work with lots of different providers and entities, so information that you share may also be helpful to some other resolution for this member as well. One of the things that I know is a struggle is getting connected for this call in a quicker amount of time. I know there's other things that we do, that collaborative case review, where we have, there's no real time frames on it. And this one doesn't have it either. But clearly, when we're talking about like a higher level of care and a crisis situation, we want to have that conversation sooner than later. It doesn't have to be with the clinicians directly. It could be a supervisor. So if there's a way for your agency to think about, who that person might be and to be able to expedite it, just so that we can have those conversations sooner than later. I just wanted to ask for that assistance on this specific thing here. There was a question that came up, and it comes up occasionally, so it's a little on the networky side, but figured we'd also put it here because it was sort of a clinically driven as well. The place of service codes. So when we say 03 for school, we are referring school as school, daycare, preschool, after school program, and summer camp. So I do realize that that's not how maybe some primary insurances refer to it. We are utilizing that as our school code. So do accordingly. There was some discussion about, well, what if the child is at home doing cyber school? We did check in with compliance, and it was discussed that really the place of service code needs to be where the physical service is happening. So that physically is happening in the home. So therefore it would be place of service home for that scenario with a kid who's doing virtual schooling out of their home and maybe getting some IBHS support that way. Again, nothing new per se, just wanted to review some of that. Again, some things have come up. Just good to remind of some of the resources we have. We have a best practices for discharge planning. We may bring back up. Emily Whalen was great in delivering that. Gosh, it's well over a year now, probably, and talking about some of those best practices of discharge planning from the time of admission. Saying some things to look for. Are we setting these families and members up for independence? Again, we've talked a lot about that with the transition to IBHS. That fear that comes out of families and caregivers sometimes when we're talking about discharge. If we're utilizing the service to the best of its ability, it's about giving these skills to those caregivers and making them feel confident while we are still there, so that when it is time to transition away, they do feel confident in being able to support their child accordingly. And then specifically looking at creating the realistic expectations and goals for the service. This isn't a service that necessarily is in place for 10 years or so. What are we realistically looking from this level of care? There may be ongoing goals, and those are conversations we can have with the families about, oh, those kind of social skills, that's something we can certainly do. On a priority level, in order to get there, we need to look in IBHS to help with this skill or this behavior before we can get there, and then look to transition them to something else a little less intensive, a little less supportive, maybe more in the natural environment. So I have heard from, and talking with the parents, the best thing to do is to be able to manage those expectations and make sure that they're clear about what this service can or cannot do, should or shouldn't do. And with the staffing that we have now and the demand for the service, we do need to really keep that in our forefront in working with the families, to make sure that we address what can and should be done within the service, and then continue them to other supports or lesser restrictive settings as well. So be happy to have you guys look at some of those additional resources. One other thing, over the last several years, Magellan has really spent a lot of time looking and tracking what social determinants of health concerns. So I think we talk about it a lot in some of the reviews that we talk about, but calling out the because I think again, with our new electronic health record, there will be some new tracking systems in place. But this, our TAR currently has this at the bottom. You may or may not have seen it, but really looking to see if we can get support in getting this filled out. It's simply the check marks, whether these are concerns that are applicable to the member or to the family. This helps inform, who's accessing certain levels of care. What are their concerns? Do we have a provider network that's able to support that? Are there additional county community resources needed? So some care managers said it's often blank. Again, if there's an ability to have that completed, I think that would help on the larger macro level. So call your attention to that detail. Something that's not that it isn't being done, but again, because we have a newer system, just like to call out that part that says attending physician fields, first name, last name, provider degree. For IBHS specifically, obviously this is for all the levels of care that we have. For IBHS specifically, most of you have figured out if that could be your written order writer, that would be helpful. Again, we're going to hopefully look to be able to get some data through our new system accordingly. So if you have the ability to specifically put that information, that would be super helpful. And that's what's meant. Again, these are starred, so they are required if you're putting it in through the online system. But that would be helpful in giving us that line of data. Another item that has come up that we wanted to share with the larger group is we've had a few providers that have struggled when it's reassessment time and the parent, or even an initial, but when a parent disagrees with the agency's assessment recommendation. So ultimately what you're requesting as far as the service level, the amount, the location, all of that. So what does your agency do? Hopefully you have some type of policies and procedures around that. One thing that has been around, honestly, back from IBHS days, which is an option on our end as well, is to have the parent write a statement explaining their reasons for not agreeing with the recommendations at the time. Little paragraph, a few sentences, to share that support. And that's something that can be included in the packet request for the care manager to review all of the information at the same time. In addition, and we tell this to families that call as well, I mean, as far as assessments and evaluations, they are entitled to another opinion. Of course, that does get complicated when we're talking about the assessment piece of it. But, you know, that is an option. And again, Magellan ultimately looks at the medical necessity and all the information supported. So we welcome having the parents' information included in there, and can review all of the information that way to make the medical necessity determination. Hopefully, additional conversations with the family about the reason for some of the change. Maybe it's a slight decrease in support, and why that would be. Again, explaining and showing all of this across time doesn't necessarily eliminate it, but for some families, it helps them to understand it a little bit better. Another thing, which again isn't a change, but a reminder, I've had this come up a little bit as well. So there is the ability to do updates to the assessment. So we've had some providers that, you know, based on the members' needs that are changing in that 6-month authorization time, they really want and feel like it's necessary to make a recommendation change in the hours, the service. You don't need to go through the whole, like what I would consider like your biopsychosocial stuff all over again. But what is really important is that the information, even if it's short and sweet, which is totally fine, that the information clearly gives the clinical rationale, it gives the data, it gives the information. Why are you looking to increase? Why are you looking to add this service? That's really the meat and potatoes of what we need. And so we're kind of considering that an update to the assessment. Every 6 months, the new assessment is needed in full. But we're not asking you to, you know, do the whole thing necessarily all over again. Give that update. So just reminding people that that's an option as a process, but that if you're utilizing it, that the information still needs to be there on the clinical data and information to support that. And my last piece, and then I'm going to turn it over to Emily. Still a little bit, we've gotten so much better with some of the input, and we're still looking at our system on ways to sort of help make it a little more obvious on what your choices are. But if you're training new staff, the easiest way to understand what they need to put in as when they're making a request on the online system is whatever those codes and modifiers are on the TAR is what they need to request in the online auth system. The billing codes modifiers specifically will be different because we have bucketed our codes. We've talked about that before. But the best way, the easiest, like straightforward, is pick up the TAR. And that's honestly when you give us auth error corrections, that's the biggest determination. If you see on paper, this is what you intended, and we can tell that, we can make that correction because we don't correct things without sort of you guys instructing us. So if we have that TAR, that's what we're going off of as well. So just want to make sure that's probably the easiest training mechanism for any new staff that are coming through and struggling. I'm not sure what to do because they do get it right on the TAR. So if we can pass that information along. So then, so that I can stop talking, I'm going to pass it on for some additional reminders and call outs from our lead autism care manager, Emily Wayland. Thanks, Emily.
Sure thing. Hey, everyone. Good morning. Thanks for working with me through the chat. Now I'm going to jump over to speaker mode. So just some friendly reminders just about CANs. If you need anything, I'm your primary point of contact when it comes to CANs. The biggest thing is that we need a CAN submitted in packets for kiddos that are 3 years and older at the time of submission. So just make sure to double check that if you have a kid that's like about to turn 3 and they're a few months away, just make sure that at the time of submission, if they're 3, you send that CANs over to us. You can do all of your CANs training through the Parade Foundation. And if you need any of that information, just let me know. I have a welcome to IBHS Magellan CANS little cheat sheet that I send out to providers, so I can most certainly send that to you all. We utilize the CANS as a way to identify strengths and needs for the member and within the family. We utilize the CANS and the results that you give us, and we look to see if that information matches what's within your packet as well. And if there are identified needs and concerns within the CANS, we want to see that you're addressing that within your treatment plans, your assessments, and your other documentation. So I'll just give a big example. If you're requesting BHT in a school, we're going to look at your CANS and see if that there was an identified need in the school setting based on your CANS scorecard. So that's just one example of how we kind of use the CANS. One other thing I just wanted to mention, you have to have the CANS actual printout from the provider website when you submit packet submissions to us. If you just give us the bubble chart that you fill out yourself, that doesn't count. We need the scored copy of the CANS. So we can go to the next slide.
I just wanted to add, Emily, as far as the reason we
sure.
switched to that criteria was the way it presents there. It really shows, if you have multiple CANs, it's showing changes over time. And that really was our way to say, hey, instead of just looking at your snapshot, let's look at it in the larger sense. And again, the CANs can be helpful, especially when we're talking about those social determinants of health issues. We're taking that larger case conceptualization. It also can help highlight some of those areas that might be barriers or things that need additional interface. So I always like to try to understand like the why. Why are you telling me I can't do the bubble sheet? Because you're getting the answers. And really it's because we want to be able to see that track over time. We think it's helpful on the provider end to be able to track that too. So thanks.
Definitely. Thanks, Crystal. And yeah, we run data. We have our own data collection regarding the CANs, and you'll get those printouts of your CANs results compared to the other BIMCOs. So lots of data-driven information with the CANs. And I saw a question come into the chat. Yes, you do need to submit CANs, even if it's MA secondary. It's just our policy and procedure that even if there is a primary involved, you still need to follow the PAHC packet requirements to submit to us for secondary fees, copays, authorizations. All right, so now we're just going to do a review of initial 6-month auth requests for IBHS. So you all know the packet requirements that we have. So we need your written order in there, the assessment, treatment plan, ISPT. If you have any type of BHT that's going into the home, daycare, camp, preschool, after school like setting, and then don't forget that CANS that we just talked about. The biggest thing that we're looking at is we want to make sure that your goals in your treatment plan are achievable. So we want to see measurable goals that can track progress, and we want to make sure the kid's set up for success. So we don't want to start a kid at so-and-so will communicate their wants and needs 100% of opportunities. That's not realistic. We don't want to set these kiddos up to fail. We want to set them up to succeed. So we want to make sure that their benchmarks are designed in a way that is achievable based on their functioning level and their skills that they currently have. So we want it to be strengths-based. We really want to see that data-driven approach again. So we want to see progress that's, again, measurable. So we want to see your frequency, we want to see the intensity, we want to see the duration of the data, and we want to make sure that matches your goals. So how you're tracking your goals should reflect how you're tracking behavioral progress. When you're looking at these topographies of behavior and, your authorization kind of your progress ranges for each packet submission. Of course, too, we want to have our behaviors that are targeted for reduction, and then our skill building goals as well. So as soon as you got manageable target behaviors, you probably are going to switch more into a skill-based treatment plan, which is totally okay. That's good. We too want to see transfer of skills. So we want to see the parents involved. We want to see the teachers involved. We want to see daycare staff involved so they can run this plan across environments. titration plan, we want to see that individualized, so we don't want to see a standardized titration plan that you use for every single kiddo within your organization. We want it to really be individualized based on this child's progress, their goals. So if you have measurable goals with benchmarks that'll lead to titration, that's great. We want to see that. Again, really individualized, and we want to set these kiddos up to succeed. And then 2, discharge criteria, that has to be individualized as well. So we don't want to see generic statements. We'll probably always give you feedback if we see another kiddo's name in your discharge paperwork, which does happen. So we want to make sure this is individualized based on that kiddo, their needs, their functioning level, and what they need to succeed in order to get to a lower level of care or show independence and success in the settings that they're in. All right, and we can go to the next slide. All right, reauth requests. We're going to be looking to see how that initial packet that you sent to us with all that baseline data, how that compares to current progress levels. So your packet requirements are pretty much going to be the same, but you're going to have updated information. So your written order is probably going to be the same unless you had an addendum, you would put that in there. Assessment, that'll be updated. The treatment plan will most likely be updated. ISPT, and then don't forget to that CANS, because we're going to look at that CANS progress again, like Kristen said. So what did they measure last authorization when you first submitted to us versus how much progress have they made in your treatment since starting? And then we'll see the new CANS results to see, are they stable? Are they increasing, decreasing in each of the domains? So again, too, we want to see those treatment goals. If you make changes to your treatment goals, we want to see that in there. So if goals have been mastered, if goals have been paused, if goals have been updated to a reflected need, we want to make sure all that's documented within your treatment plans. The interventions, we want to make sure that they're broken down per role. So we don't want to see like a BCMT and a BHT doing all the same things. So interventions need to be individualized. And 2, we want to see how the parents are running the interventions as well, or the caregivers and the teachers, so on and so forth. Again, we want to see your frequency, intensity, duration that matches your goal and how you're tracking progress. So, and it needs to be comparable to your baseline data. Unless you're changing the way that you're tracking your data, you're going to have a new baseline then, or a new measure of frequency. Progress, it's great if you can include how your kiddo is doing in treatment. It's better if it's measurable progress. Again, we really want to have that data-driven approach. So if you want to put a breakdown of how the kiddo is doing with, percent ranges or, a range of scores based over the authorization period, that's great. If you're making changes, to add that in there. So maybe a kiddo is not meeting their goal, maybe they are regressing. We want to have a little snippet in there of how you're going to adjust treatment to support that child. Again, transferable skills, when we went over that, and titration and discharge criteria. Obviously, you would update that based on the kiddo's needs. So it's probably not going to be the same as when they first entered treatment, just based on progress. All right, next slide here. So request for additional information. So I'll just start it off. If we have any questions that we may have, if we're concerned about medical necessity, we can send that request for additional information at RAI. Basically, I like to say, we're not mind readers. If we can't find it in the packet, we're probably going to ask. So it's not our job to assume. This is just a way to get additional information. I can speak for myself and the other care managers. A lot of the times we get way more information from you, and things make sense when we're on that telephonic call. So, it's just a way to get more information that may not be in the packet. And also, too, John Siegler, our psychologist advisor, he popped on the call. He will probably do 99% of the possible peer-to-peers if your case goes for a peer-to-peer. So some things that we may send a request for additional information for is, you know, if we don't see that measurable tracking of your data. So we want to see what behaviors are occurring in each setting. So if you have a kiddo getting services in a school and we don't have any behaviors or any information about the school, but you have home and community data, we're probably going to send an RAI because there's really no justification to support that need of services being requested in the school if there's no data to back it up and support it. So we want to see, we might have questions about your assessment. So if you don't have an assessment at all in your packet, you know, we'll request for that. But we also want to make sure that there's structured tools in there. So your FBA, your VB map, your Vineland, depending on the kiddo's needs, you'll individualize your assessment for that. And along with that assessment, we really need to see those observations. So observations need to occur in a natural setting. So the home, the school, the community, you know, we don't need a center-based observation. We more so need those naturalistic observations of the child. And we really want to make sure that's broken down per setting. So we want to see the date of the observation, the time, and then where the observation occurred. So sometimes providers will just say 3 observations occurred. That's not going to count. We need more individualized information about those observations. If there's no information regarding goal progress or the behaviors and whether they increase, decrease, stayed the same, we're going to ask information about that. If I'll say we are big proponents of parent goals here. If you don't have parent goals, we're probably going to ask about it. That's just very important to set these kiddos up for success. So if you have parent goals in there that follow all of our other guidelines, you're probably going to be okay. Same thing with transfer of skill. We want to make sure that's a part of your treatment planning. And then if there's any barriers, so I just wanted to throw this out there because we see this come in all the time. A diagnosis can't be a barrier. So just because a kiddo has autism doesn't mean that that's a barrier. So if try to avoid and don't put your diagnoses as barriers. We'll probably have a discussion about that. We're going to look for things that are impacting treatment. John Siegler has given me the thumbs up. John is a pro at this. So if you have any additional questions, I would go to John. I'm sure he'd be happy to meet with you. And 2, we want to make sure you're actually looking for social determinants of health. So I know we have that little check mark on the TAR. A lot of the times, though, we'll see none known, but then we go through the packet and we'll see there's housing issues, food insecurity. We want to make sure that there is a plan to address that. So maybe get the family connected to a BCM for resources. So these are just some things that care managers kind of look at and flag. If we can't find this stuff in the packet, if we can't get a hold of you for a quick phone call, sometimes we'll give a phone call. I just did this to a provider yesterday. I'm like, hey, I don't have a final assessment rec. Like, can you get this over to me? Sometimes we can avoid getting that RAI out, and we'll try and do that. We want to work with you. Unfortunately, some cases we just can't do that, and we'll have to send that request for additional information. We'll put a line in there about possibly needing to do a peer-to-peer with John. Sometimes we'll move forward with that. Sometimes we have all the information we need and we don't need to move to that next step. All right, next page. And then I guess I kind of went over this on the last slide. Sorry, I kind of talked a little too much. All right, so just additional tips to avoid a request for additional information. So if you do have a change of script request that comes through to us, just be clear about what you're changing. The easier it is for us to figure it out, you probably won't hear from us, I should say. So just follow our different workflows when you're doing different types of change of script. So there's a workflow that if you're changing a prescription, and it's just an increase of hours within the same setting. That's one. Then we have another workflow for a change of prescription for a different setting that's not already included within the authorization. And then we have a full change of prescription for level of care. So that would be a switch from IBHS individual to IBHS ABA. So just make sure you're following those 3 different workflows to do the change of script appropriately. And of course, if you're adding a new setting, the biggest thing, we have to see data about that setting. So I would say one of the biggest one that comes in is adding services to the school. We need to know where this kiddo is going. What's the school? Do they have an IEP? What services are included within the IEP? What type of support classroom are they in? Do they have a PCA in that school? Provider needs to be, school rep needs to be included in the ISPT. And then of course, we want to see data within that school setting to justify that script. If you have a kid that's stable, you're not changing the prescription, make sure you're putting in that clinical rationale, your justification for what you're recommending. And that, I shouldn't just say for if you're keeping the script the same, it should go for any type of recommendation. So when we get to the final assessment treatment recommendations, we want to see the input from the assessment clinician as to why they're either A, increasing the script, B, decreasing the script, or C, keeping the script the same. So that clinical rationale is big. We just don't want to see a chart that just has the numbers and hours per month and the service. So we want that clinical input. You're all clinicians. You're all great at what you do. We really want you to back up your work and show off your skills. We talked about progress a lot. I'm not going to go over that anymore. And all this other stuff, we pretty much went over. Does anyone have any questions? Sorry, I feel like I talked a little too much.
My fingers went too far. Sorry.
No worries.
I didn't mean to cut you off. It wasn't like
No, all good.
All right. Well, thank you. And then I'm just going to share some clinical data updates that we have. So Q3 data, which Q3 was for our providers that start with A through I. The scores looked really good and are showing really nice trajectory on our clinical measurement tool. I highlighted in green all of the ones where the total scores in those areas. So again, written order, assessment, treatment plan, were increased from the last quarter, which would have been Q1 for the same provider group. So as you can see, that's a lot of green, which is really great. And I wanted to note, even when Emily was talking, a lot of those things, I know maybe things that you guys have as a final destination, that's what you want ultimately. And hopefully, we can get on the same page. And I know that there are providers actively working to ensure that their staff can get to that point. So we want to support you on that. What I can say, and you can see for yourself, at least even for just this quarter, the assessment scores in the time that we've been tracking have gone up considerably. I know Dr. Siegler has done a lot of his best practice trainings on assessment, and you guys have really devoted a lot of time to increasing that piece of the work. I think what we're seeing now is maybe some shift in focus now on some individual treatment plan. So we have asked Dr. Siegler to support us and the provider and you guys in the provider network with some additional resources, best practices, discussions, and really trying to do that as a focus for this coming year. So in the meantime, we do have Q4 obviously closed. We're just getting all the data together, so I will be able to share that at the next webinar. But congratulations and kudos to those of you that are working so hard to increase all of those areas of treatment. Oops, I did all just share that. I totally forgot I had that slide, sorry. And that basically said is the assessments have been really nicely improving in their overall scores that we can see for when it was started, and we'll focus on some treatment planning. So next quarter webinar, again, I want to share the Q4 data for these J through Z providers and compare that to their Q2 results. We'll share the cumulative data for 2023. I was just shy. It was a little too early in January to get the entire 2023 data all together. I tried, just wasn't happening. And then I also tried, but I couldn't get it done. The OMSA state report was due December 15th, so it was turned in. I'd like to try to be able to synthesize that like I've done before and be able to send it. It did shift. It's a rolling year, so some of the data looks differently than it may have before. But some of the things that are sort of looked at in that report is, how long is it taking to get assessments done on average? How long, and even based differently on the counties, how long is it taking to get from the written order to the assessment process? How about the end of the assessment to the start of treatment services? So that's some of the data that I'd like to be able to share. The other thing that the IBHS team got together and talked about starting for this coming year is to do something we're calling provider spotlights. We've talked internally that many of you have some either unique, innovative, solid best practice type things. And we're looking to outreach to you guys to share some of that with this larger provider network. So we're doing some brainstorming. Hopefully in the next 2-3 weeks, we'll be outreaching some of you to try to put you into either the next quarter or, quarter 2, 3, 4, to try to be able to highlight some of these best practices, innovations, things that you can share with the larger network if you're comfortable doing so. So that will be something that we hope to start then for the quarter 2 webinars as well. This is something that Emily spoke about last quarter, so it's not new, but just a reminder, again, as part of that new data report for the state, they added, everything previously was a claims-based report. They added a piece of having a written order assessment that doesn't hit our claims system. So we have, on many occasions, written orders that are done maybe by a developmental pediatrician, even a primary care physician, things like that, that don't get billed in under the 90791, the H0031 codes. So our report wasn't necessarily capturing that, which was fine. We understood why that was. This is trying to capture some of that information in a different way. We're trying to brainstorm the best ways, and there'll probably be new ways to come up with. But if you have somebody that calls in or that sits on a wait list specifically, maybe wants you guys as an agency, and they're waiting a little bit for some of your staffing, and you've seen their written order, and their written order does come from outside of sort of the traditional network that would have billed it that way. If you could send this information to that IBHS email box, we then add that information to our tracking sheet, which gets combined into the larger state report. So appreciate that. Again, this information will get posted on our website so that you have that accessible when that type of scenario comes along. I did want to share that there were 2 new things that have come up, and they've been around for a little bit. There was in the Lehigh and Northampton, previously there were several videos shot together, some with provider involvement, in the videos. It was great, professionally done for BHRS to try to help explain to members of the family, community members, daycares, schools, sort of what's the process, what's the goals, and what do we do with BHRS. It became unfortunately outdated when IBHS came along and the information wasn't applicable. So there was discussion of, hey, we really still could use that resource. We didn't get enough bang out of that one. Can we try to do something for IBHS? So there's 2 pieces that are happening. One, this is already posted on various websites, on the member page on our website, on the provider page at the bottom for IBHS. You'll be able to see this video. And it's kind of an intro. We do have plans that we want to have I don't know if it'll finally be called a myth and fact sheet, but something on that end as well to add another level of conversation around, what are the myths around the services? What are the facts around it? And to help support you guys in having conversations that and questions from community members, from families, from our kids in what this service can't do, what is it designed to do. So I'm going to attempt to be able to reshare this. So hang on. I'm gonna pull this up so that I can indulge. It's only a 5-minute video. That was important to be short and concise. So I wanna, give me 1 minute. Okay. Okay, here you go.
Have you noticed a recent change in your child's behavior? Are they having trouble getting along with friends? Are they unable to speak? Is this new behavior affecting your family? If you are concerned, remember that your child's doctor can help. They may also suggest that your child see a mental health or behavioral specialist. Today we'll be talking about one such service known as Intensive Behavioral Health Services, or IBHS. Some scenarios include missing developmental milestones, delayed communication skills, displaying aggressive behavior, and other behaviors you may be concerned about.
IBHS is an individualized behavioral health service for children and adolescents. A team of trained professionals work with children and families to address better coping and functional skills related to mental health and autism diagnoses. Services wrap around in-home, school, and community settings based on written order and assessment recommendations. Generally, all IBHS services are designed to teach children skills needed for success. Services help increase coping strategies and support skill development to promote positive behaviors. They do so by developing a plan of care and support which involves the caregivers, educators.
I'm going to try to reshare. I don't know why it's doing that. So hold on, because that would be a shame if you can't see it all. Okay. Thank you for letting me know. Here you go.
Foster and kinship care, and others meaningfully involved in a child's life and development. Applied Behavioral Analysis, or ABA, is a type of IBHS services. The services are evidence-based and are data-driven. You might think that ABA is only for kids with autism, but kids with other diagnoses can qualify. ABA services explore why a behavior occurs and then uses interventions based on this information. IBHS services are delivered individually, in groups, and/or center-based locations, and children can get more than one type of service.
IBHS is available to children with a behavioral health condition. Services can start upon diagnosis. Usually it will be for a developmental delay or a behavioral health concern which is screened as part of a child's pediatrician visit or school entry. Services are delivered during childhood, up to age 21. Services can be delivered as long as needed, with regular reviews to determine continued need. Behavioral consultants, or BCs, are the leaders of the child's care team. BCs develop treatment plans and complete assessments. They monitor the work done by the behavioral health technician, or BHT, and work with the families and caregivers to build skills. Other IBHS team members could include licensed behavioral health consultants, board-certified behavior analysts, behavioral health technicians, and/or mobile therapists. Mobile therapists could be used to provide therapy to a child, youth, and family to process feelings and emotions within a home and community setting, and can be used to help a child, youth, or young person process emotional difficulties, trauma, and behavioral health problems. Along with professional support, family and school daycare support and participation is key to successful treatment. Family members are expected to participate in treatment and follow the recommendations of care. IBHS team members are not to replace the child's caregivers, but to help support and guide the family to lasting care.
The first step to get IBHS services is to get a written order. This can be completed by a primary care doctor, a specialist, or one of Magellan's in-network providers. There's a form on Magellan's website that your healthcare specialist completes. Families should give the written order to an IBHS provider to begin providing services. Written orders are good for 1 year. The next step is the IBHS provider will begin with a comprehensive assessment of need and a treatment plan. The younger the kids are when starting treatment, the longer the parents have this skill set to apply with them. Services can be supplied in your home, at your child's school, at a provider's office, or in the community. Having someone come in your home can be difficult, but the benefit is great. However, the shortage of behavioral health professionals coupled with the increased demand for services means it can take time to get services initiated. Please be patient. And be sure to communicate changes in your child's behavior to your provider while waiting for services to start.
Magellan is available 24 hours a day to coordinate support for families during this process. This includes the option to file a complaint or a grievance if you disagree with the provider's approach or Magellan's authorization. Families can also request a second opinion. Our website includes a provider search tool and information about how to contact member services for each county we serve. We understand that this process can be challenging, especially with an increase in demand for these services. Hopefully, this overview of IBHS has been helpful. For additional resources, please go to our website on the IBHS members page to find service descriptions and other helpful documents for families. If you have any specific questions, please send an email to ibhs@magellanhealth.com.
All right. Well, hopefully you like that. I see some positive feedback thus far. It's going on its own. So it is on. So if you have the Magellan of PA website that specifically has the IBHS provider page, I don't know if Emily can grab that quick enough. It is at the very bottom. That video is there. I saw some questions around that. Also on the members page, I think there's the IBHS. The IBHS webpage. It's at the bottom of there as well. So it is available. And of course, I have the link from the member page on this slideshow as well. So about embedding it onto your own, I would have to run that through our communications director, but we are certainly happy to have you share the link, show the video, during an intake or something together. If you have access, like on a laptop, pull it up. That's, one of the things that providers were asking for is this is something that, you guys created. It's not just coming from us, and it kind of helps explain a little bit about the service. Let me go back to our slideshow. So keep the feedback coming. Hopefully, was something that you guys liked as another resource. Another resource which I wanted to share, and I probably should go on the website itself, is again through that Lehigh and Northampton has an Autism Action Committee that has done a few different projects, and one of them was a different navigation guide, more for kids on the autism spectrum, on the sort of beginning of things like how do I even get medical assistance? How do we get an evaluation? We know something's happening, sort of that beginning. That is still posted, and honestly, it's still something I reference quite often. Well, in the last few years, there's been more sort of even community level shifts to talking about transition age supports and needs. So the group talked about doing and was able to complete a transition age navigation guide, which is now available to everybody. So we did sort of outline, I'm going to try to pull it up at the same time so I can maybe share that screen. I'm going to shift so that I can show this to you guys, kind of walk it through a little bit easier. hopefully I'm doing this. Okay. So I'm on the autism resources member page. If I come down here, there's this navigation guides. The family navigation guide, that's the one I was referring to, has like that earlier piece. So when we were used to get a lot of calls about, oh my gosh, I just got a diagnosis. What's my next step? Or I don't even know, what to do. We have some resources there. So this is the transition age navigation guide, which you're talking about now. So the navigation guide itself, I'm trying to pull it up here. Okay. Try to just give you the table of contents. We tried to go through and highlight lots of different areas of need and give just little bullets of information. So everything from education, community living, legal considerations, employment, even the Office of Developmental Programs, and give some of that information. So I'll just scroll down a little bit to the sections. I'll just get to a little bit more. So like education, high level information. What I also find is really interesting, and I'm going to go back so I can highlight this. We also had an online resource guide. So instead of keeping it all as one package, we pulled out the resource guide so that we can continue to update the resources available. Now, some of this is specific to Lehigh Northampton, but there are many, many things that are either PA specific or national even. So although this was somewhat designed primarily for Lehigh Northampton counties, you can tell that there are things like PA Teen Safe Driving Resource Guide. That is well beyond Lehigh Northampton resources. So it may be something that is an additional benefit to have people thumb through if they're not in those two counties. So I wanted to make sure that you guys were aware of this additional resource on our page as well. Go back to the other one. Okay. Emily, I've totally not been able to keep up with chat, so it's all you, girl. Chip and hip.
We're good.
Okay, I figured. Chip and hip resources, so the Children's Health Insurance Program and Health Insurance Premium Payment Program. We've heard a little bit about this in some of the changes that have happened with the MA unwinding, some people losing their MA, people who have not been submitting paperwork during that COVID span and now are expected to do that. I wanted to offer some resources. I am not the expert because these are certainly outside of the Magellan realm, but I wanted to sort of give some of the resources that we have related to figuring out or giving just more information. HIP was something honestly newer to me, so I had done some research to figure out what that was about. Compass is a really helpful tool, and just to make sure everybody's aware, Magellan is the behavioral health MCO contracted to those certain counties that we work with. We don't control anything related to the actual benefit of Medicaid, qualifications, anything like that. We are given the membership to help work with from there. So it's that county assistance office that really makes those determinations, takes that paperwork and does all of that. So when there are issues with active Magellan or not having the Medicaid, that's where you tend to hear us then refer you back to Department, of Human Services, the County Assistance Office. Compass is a nice sort of online resource, a little bit quicker than maybe trying to reach somebody via the phone. If it's possible, they have a bunch of online service resources. So see if there's some resources there. Another piece, again, as you guys have new staff that are coming on as case managers or whatever, we have more information and resources available regarding the online authorization system. Some guides, how do you check authorizations? I think we're still having a lot of those questions come through. Things are not really delayed the same as they used to be with our old system. So once it's in our system, you pretty much have that access. You can search by a member, you can search by your provider MIS number. and get a list of your things. So I really encourage to offer this as a resource to any new staff so that they can, you know, have an easy guide next to them, hopefully to be able to put the requests in seamlessly as possible. We have some other resources. Crystal talked about Avality. They are the people that control sort of that website. They have some resources available as well. We have our IBHS provider website, which has a lot of our forms, some of our best practices, has all of the, you know, I didn't say all because we did take out the ones that are, you know, outdated now, but the newer webinars giving this type of information. We have the PowerPoints, we have the recordings if we had them. And then we do have a new provider training that we often give out a lot of resources from there, how to complete forms, and sort of, you know, key points as we train a new provider and coming on. But it may be something that's valuable to just a new staff person. So you can certainly ask us for those resources as well. And our Q2 webinar is now scheduled for Thursday, April 4th from 9 to 11. Again, it's another registration. This is available, or it will be after this gets posted. This webinar will get posted. Then we update the flyer at the bottom of our webpage with this information. So if you ever can't remember, oh my gosh, what did we say the next webinar was? I didn't write it down. You can go to that website, and at the bottom there's a flyer with this information. So make note of that. Good attendance continues. We appreciate that. And Emily, I'll ask you if there's any questions from the group that you think the larger group would benefit from, or we need to get clarification on before we end today.
I think we're good to go. I just wanted to add, and Christine noticed this too, just a heads up that the new law for school is up to 22, like your 22nd birthday.
Yeah, I think we did that in our one before, but yeah, thank you for calling that out. I think we had it in our last webinar or so. Thank you, Christine.
Oh, and then we have one message that just came in from Ashley. So Rob had to leave, but message that he wanted to bring up that our state rep gave us feedback that we cannot discharge due to lack of attendance. For example, a client has not been attending services for an extended period of time, more than 60 days, and the family was not actively responding to outreach. He said we need to use information about the lack of progress versus our attendance policy.
And I think there's some things in the regs about that piece. So I'm sorry that Rob had to go because he was one of our superstars in our video here. So more to come. I guess Rob would probably be open to some additional contact about that as well. So it sounds like that was coming from the field office when they had a license review. So thank you for sharing that.
And that's all we have in the chat.
Thank you so much for your prompt attention. This was longer than usual, but I think helpful to have some additional items like from compliance and such. So continue to keep any ideas coming about things you would like to hear about in the future or additional areas that we can do some additional reinforcement on. Again, usually we do a pretty quick turnaround on posting this to our website. And again, let us know if you have any questions or concerns or anything that we can do to help in any of the service delivery to our members. So thanks all. Happy 2024.
Thank you.